Dr. Jose Soriano could join us. He's from Mexico and he's one of the experts in endoscopic spine surgery. He will tell his experience on cervical posterior tubular decompression for cervical spine stenosis. Yes, Jose, welcome.
Thank you so much, Mehmet. First of all, I hope you are well, everybody, in the medium of this terrible pandemic. In Mexico, we are in the worst moment, absolutely in the worst moment. The hospitals are exceeded, so we are afraid about. So what bless us. I'm going to talk about minimal invasive cervical posterior decompression and cervical spondylotic myelopathy, and a very brief experience about it. This is my hospital, ABC Medical Center, Campus Santa Fe in Mexico City. It's a very small private hospital, but with all kind of technology. I have not one conflict of interest. And DV could be summarized in this way. In the decision-making process, and agree with the evidence-based medicine, the posterior approaches for the cervical spondylotic myelopathy are indicated in cases in which the compression is circumferential or posterior preferentially. In patients with moderate to severe myelopathy, that is less than 12 in the modified Japanese Orthopedic Association scale, preferably when the patient is stable, but not necessary. Better when we have more than 2 levels of compression. When the comorbidity of the patients include OPLL, osteoporosis, carotid disease, or previous surgeries. In those cases, absolutely could be indicated the posterior approach. And the options in those cases are endoscopic techniques or microscopic techniques. I prefer absolutely tubular microscope-assisted techniques, including unilateral laminotomy with bilateral decompression, hemilaminectomy, or laminoplasty could be applied. In first place, it's very important to recognize that when we respect the midline raphe, as was described in this important paper in the journal Neurosurgery Spine, we are essentially respecting the innervation of the third occipital nerve and avoiding the very painful condition that witness the usual evolution in the posterior approaches. Also, when we go behind the raphe, midline raphe, we are preserving the ligaments. And it's very, very important because we are preserving also the contralateral side, the which stay intact, essentially, as you can see in this diagram. So in this condition, we can maintain the stability and lordosis. That is the biomechanical issues of the cervical spine. The surgical position of the patient is crucial in these cases, and we usually use a Mayfield holder to maintain and modify the position of the neck properly, avoiding face and knife injury. A discrete semifowler could decrease the peridural venous turgor. It's very, very important. Don't flex or extend because it's not necessary to prevent a noticed damage of the spinal cord. Is very, very important. A general intravenous anesthesia with propofol and fentanyl infusion, practically without muscle relaxing set for intubation, could allow us a true input-output neuromonitoring, which is absolutely mandatory in this kind of techniques. Are necessary fine-tipped instruments and tubular access system, whatever you have, and curves and long, very microsurgical tools, match head drills is very important. Don't use cutting drills because there is to create a leakage. Or better, in the last times, I'm using a ultrasonic scalpel with advantage to make at the same time hemostasis in the bone. The selection of the approach include the site of the worst compression or the site of the radiculopathy. It's very, very important. Remember that in the past, we were using, in all the cases, a K-wire to then introduce the tubes by dilation. But now I can say absolutely it's very important to avoid K-wires and progressive blind dilation to don't chop the dura, or worse, to don't chop the spinal cord. A better technique could be a progressive microdissection following the direction of the muscle bundles, as you can see, including the different layers of the muscles: trapezius muscles, semispinalis cervicis muscles, splenius cervicis muscles, and multifidus. It's very easy, as I will show in the next slides, if you use a pencil, an esophagus retractor, and micropolar. With those three instruments, it's very, very easy to complete this goal. As you can see in this short video, the incision usually about 2 centimeters, we can dissect with the bipolar and small esophagus retractors, as you can see, following the bundles and making hemostasis of the small vessels to maintain clean the anatomical layers, the surgical plane, because it's very easy. And we can take advantage of the esophagus retractors to dock the tubes and to maintain very clean the bone plane, as you can see in this picture. Once you have the bone plane, we can drill following the landmarks, anatomical landmarks, in this very, very, very easy way. So the learning curve is very important. You have to learn at the first to use all kind of the instrument, but they are very, very small tubes, diameter about 10 to 20 millimeters, all depending of the number of levels to be operated. So the surgical landmarks are very easy to identify. The first one is the interlaminar space. The next one is the laminofascial junction, as you can see, docking the tube about 2/3 over the superior lamina and 1/3 over the inferior lamina, because with this position, we can achieve the flavum insertions. And we have the possibility to wind the tube in craniocaudal or mediolateral way to wide our field of action, as you can see in this diagram. So The tube offers a wide surgical action field. The tube doesn't limit us our action over the goals. The key goal is absolutely spark the tension band and complete the phloem resection to make a very good decompression. The first, once we identify the bone plan, the next step is to drill the bone until identify the limits of the phloem ligament, as you can see perfectly, the superior and inferior limits. And it's very practical and very useful to be sure that the decompression has been completed. You can see the limits of the phloem. Sometimes we find scars behind the phloem. That's the reason why it's very important to complete the resection of the phloem. This is one case with a very, very important compression, one level to see the position. The tube was 10 millimeters, medial caudal, very easy to identify, following the step by step, as you can see. And at the end, with the phloem resection, we have the possibility to tilt the table also to complete the contralateral side of resection. The hemostasis is very important, and I highlight this: don't use too much bipolar. It's not necessary. We have to be patient, only a little bit apart. Some minutes is enough to make a good hemostasis. In the most of the cases, we don't use bipolar or anything to make hemostasis. It's not necessary. And you can see here the preservation of the muscles perfectly at the end, and a very good decompression with the complete resection of the phloem. So you can see the window of the bone respecting more than 50% of the facet joints to don't create instability, in a very good clinical evolution, which is the most important reason to make this kind of procedures. The good immediate postoperative evolution. This is another case with a multi-level compression, not only spinal cord compression, but also some levels of radicular compression. So this is a good example to show how it's possible to make multi-level spine procedures, including laminotomies, laminectomies, or foraminotomies, whatever you need to complete the goals. This is again and again the same issue. The sonopet is very important tool to complete the foraminal decompression. With the sonopet, I have accelerated the times, absolutely. It's very, very easy because the way of the tools facilitate the completion of this kind of procedures. You can see a little bit Litene getting better the monitoring during the surgery, the decompression of the foramina and laminotomies combined. And this is another case just to show a laminectomy. You can see a multi-level compression in a very rigid spine, stable spine, the patient confined to wheelchair. You can see again and again the position, don't flex, don't extend, it's not necessary. Muscle dissection following the bundles, landmarks identification, phloem resection, identifying the superior and inferior limits, tilting the table sometimes when it's necessary, and making a very, very nice and wide decompression using two hands, three-dimensional vision, high definition, preserving the muscles, and completing the goals of the minimal invasive procedures. And you can see 3 levels of laminectomy, preserving the lordosis and stability of the spine, and preserving the raphe in this post-op CT and with a very nice post-op evolution. We report these preliminary group patients with Roger Hartle and his group with excellent results. Mean pre and post-op VAS from 6 to 1 and NDI from 46 to 7 respectively. So nice results. Another possible technique could be the open door laminoplasty. It's a very complex procedure that was described by Michael Wan, the feasibility by MIS. And then we report this paper in the literature highlighting how to make this important procedure, starting by the short laminotomy and then the hinge, etc., level by level. This is a 71 years old woman, long history of progressive cervical axial pain with radiation to the left side, myeloradiculopathy, and Jupiter motoneuron syndrome, MGOA 6, and you can see a very rigid spine again, but with anterior subluxation, C5, C6. Multi-level important compression, basically from C3 to C7, and different sequences of the MRI, just to make the important compression, especially in C3-4 and C5-6, when intensity change in the MRI, as you can see. So the normal bone density was normal, and the surgical challenges were to make a good decompression, to preserve improved neurological status, to stabilize C5, C6, avoiding a very painful post-op condition, all of them by tubular approach. And you can see in this short video, the last video, how we can identify, again, the muscles, the position, etc. And at the beginning, we make the holes of the facet screws to avoid the risk of some kind of danger deviation of the same. And then the hinge with the ultrasound scalpel in a very fine way. And at the end, the plates to make the laminoplasty. As you can see, 2 incisions, 2 centimeters, and the best is the immediate evolution of the patient. So you can see here the widening of the canal, very impressive widening, and the patient getting better until 15 in the MJOA, and you can see in the evolution in the time when preserving the widening and the fusion of the hinge, etc., etc. In summary, in conclusions, the posterior microsurgical tubular approaches are useful to solve uni or multi-level spondylotic myelopathy. The goal must be to complete the main objective and agree with the universal guidelines of the EBM, but minimizing the iatrogenic damage. The feasibility depends on the interest to learn the skills and the good disposition to get a slow learning curve. The understanding of the step-by-step could facilitate the shortening of the learning curve. The knowledge of the possible complications could help to avoid them, And it's mandatory to cumulate casuistics to analyze results to understand the true clinical impact of these techniques. But the most important, absolutely, and I have to mention to end this talk, is the clinical situation of the patient. This is the patient 12 hours after the surgery with a multi-level laminoplasties, and you can see how the patient is absolutely better and with minimal pain in the immediate postoperative. Thank you so much, Mehmet. Thank you so much for everybody. I hope you are well in medium of this pandemic. Thank you.
Thank you, Jose. Great talk. Yeah, very interesting approach. Are there questions from participants? Salman?
I think, Jose, as always, a brilliant talk. Really enjoyed that. I think the videos were very self-explanatory. I really enjoyed that. And it's good to see you healthy and well. And please take care of yourself.
Thank you. Thank you so much. Thank you, my brother, Salman. Thank you.